That's what's left over.
It is liquid. Yeah, it's made of water. Definitely some of it.
All righty, boys and girls. Tonight, we're gonna learn about geriatrics.
Why are you restarting?
What?
I said, why are you restarting? You already said that.
Now we're recording
Okay.
for all the people watching at home.
Oh.
All the people from the YouTube channel. Like and subscribe. You guys okay?
Yeah.
All right. So what are geriatrics? Oh wait, we got any thoughts for the day first. What was that thinking? All right, you're likely not for any of your patients or your family, their family, not your family. That you come into contact with today. They're going to likely remember you for the rest of their lives. Be sure to leave an impression to yourself, of yourself, that you want to last a lifetime. Any questions? I don't know why their thoughts for the day is with geriatrics, because they generally don't have nearly as much time as younger.
Yeah, I don't remember them.
And they don't remember either, you're right. Any questions? That's very stereotypical. We're gonna go over stereotypes. What is a geriatric? Generally considered over 65 years of age. 5 years ago, it hit over 50, I believe we're over 60 million now. That's Chewbacca. You guys never seen Star Wars?
It's just a new one.
Guys, you don't know what a push me pull you is. Do you at least know what a Wookiee is?
Yeah.
All right. So geriatrics are a huge, huge part of the EMS system. There's a couple of special things we need to do when dealing with geriatric patients. So, when you get a call for a geriatric, you can tell Pat to take a rest. Yeah. The guy needs a break after all those sick kids. It could be her. Pat's also a female name. It's non-gender specific. That's why we use Pat. So instead, I'm a little out of sorts tonight. First of all, let's talk about communications. Show them respect, get at eye level, let them have time to answer. They don't just blurt out answers. They usually think about the answers, then they give you the answers. And be patient with the patient. Any questions? They need a little more time to process what you're saying. Any questions? All right. So instead of bringing Pat with us, we're going to bring the Gems Diamond. That's what the Gems Diamond is. G is for, are they of normal age and typical presentation? E is for environment. Are they safe? Are they neglected? Do they have what they need to take care of? Are there tons of stairs? Is the house in disrepair or unsanitary? What's their medical assessment, past history? And do they have the basic social needs that they need? Or is everyone in their life dead? They've outlived them all. Any questions? Like Chewbacca, Scooby-Doo, everything's going on today. Any questions? So, what kills geriatric patients? Well, number one is heart disease. However, that's misleading. Because geriatric patients have a better chance of surviving a heart attack than people in their 40s. Because they have collateral circulation. Collateral circulation is when, as you get older and your arteries get plugged, your heart starts growing new arteries, like a lizard grows new tails. So they actually have collateral circulation. So the blood goes around. They grow more arteries the older you get, so you actually have better perfusion to your heart. Well, you don't have better perfusion, but you have more pathways. Yeah. Lateral circulation is a real thing.
What is that?
Cancer, what's the number one risk factor of cancer? Anybody know? No, it's not smoking. That's what everybody says. What?
Diabetes.
Oh, they say diabetes. Yeah, that's usually the end result. No, not diabetes. Number one risk factor for cancer is age. The older you get, the more likely you're going to develop some type of cancer. I don't know. I think it's because the older you get, the more you're exposed to and the regenerated cells. Because cancer is an abnormal regeneration of cells. So the older you get, the more environments you're exposed to, and the more things happen, the more your risk factor goes up. Stroke. Then, of course, COPD is right there, then diabetes. And then, believe it or not, trauma's like sixth. Any questions? All right. Stereotypes, since Brachet brought it up. Not all elderly geriatric people are confused, sick, sedentary, and immobile. Some lead very active lives. Any questions? They do get some physiological changes though. Skin is susceptible to injury, takes longer to heal. Nerve endings don't work well with your sensory nerves. And the more you breathe into environmental problems, the more clogged up your airways are going to get. Any questions? Despite collateral circulation, you do have an increased risk for cardiovascular disease, which is the same problem with your kidneys, also have lack of perfusion. Sometimes your memory starts to go too. And you get decreased psychomotor skills and fine motor skills. Any questions? This is a pretty depressing slideshow. All right. Decreased muscle and mass strength. And your GI system doesn't work as good. It doesn't push the poop through nearly as well as it used to. Any questions? All right, polypharmacology is a huge problem. Polypharmacology means when you've had at least 4 or more prescription medications. A lot of geriatrics are polypharmacology. And when you start getting that many medications, then you start getting things get real complicated as all the side effects start working with each other and against each other. I'll give you an example I give to every class. I know of at least 3 cases I can think of right off the top of the head, one of them being my aunt, where they were diagnosed with Alzheimer's. And then when they had to be moved or switch doctors and they were taking off all their medications, they were on like 18 to 20 medications. Suddenly their Alzheimer's was gone because it was all pharmaceutically induced. So the example of my aunt, she was a nun in Buffalo, who a bartender at an Irish pub found walking down a back alley at 3 o'clock in the morning as he was taking the trash out, and brought her inside and got her a cup of coffee and called the convent that came and got her. They decided it wasn't safe for her there anymore because there was too many ways to get out. That's a big old ancient convent. So they sent her out to the country to a spot they got there on a ranch, and they had to switch doctors and she was on 18 medications. So he couldn't make heads or tails of medication. So he took her off everything, said, then we'll start over. We'll start treating the symptoms. Go. Not a bad idea. And within a week of her stopping all the medications, she no longer had Alzheimer's because she never actually had Alzheimer's. It was pharmacologically induced. Any questions? Another thing that causes confusion, altered mental status in geriatrics, is often a UTI. Matter of fact, it's one of the most common things that causes that in geriatrics. Don't know if there'll be a test question on it, but it's a good patient assessment question for you guys. Any questions? Syncope is common. They don't have the ability to vasodilate, vasoconstrict like younger people do, so they stand up too quick, or they have an arrhythmia or something else. Their vascular system cannot compensate as quickly, and you may have a lack of blood flow to the brain, which then causes syncope. Well, that's bagling down. So when they go to the bathroom, their GI tract doesn't work as well. So, and also usually on some type of pain med that's usually narcotic, which then dehydrates the intestines. So then you get this hard brick of stool. And then they bear down on the toilet trying to poop, which then stimulates their vagal nerve, which then gives them bradycardia. And then, yeah, they can't compensate the vasoconstriction. And they die on the toilet. The heart stops. Well, it's all fluid. It's not getting enough fluid. GI tract is already not in the same condition it was when they were younger. And then, yeah, they get constipated. And then when they bear down, they bagel down, and their body can't compensate. It can't compensate. Kind of like what happened to Elvis, but at a much older age. Elvis couldn't do it because he was on so many drugs that he couldn't compensate. Questions? Anybody know who Elvis was? So heart attacks. So if you guys remember in cardiac emergencies, 1 in 4 heart attacks is a silent heart attack, 25%. The majority of your silent heart attacks are geriatric defects. They do not present with the classic chest pain symptoms. They generally present with weakness, nausea, diaphoresis, and skin color changes. That is the classic signs of a silent MI in a geriatric defect. Any questions? Yes.
So how does that work? If they're trying not to call 911 once a night.
No, they usually do. They call for weakness or shortness of breath. And they got kind of an ashen color to them. They're weak and they're sweating. You should be thinking possibly a heart attack. They're a female and over the age of 65. Actually, a female and over the age of 55. Start considering. Any questions? Acute abdomen. Aortic aneurysms get more likely the older you get. And they may also have GI bleeding. Now, if they're obese, we call it an obtusat. Geometry people. Yeah, that's not true. Acute's less than a 90-degree angle, obtuse is more than. Give up. Such a hard freaking crowd. Oh, frustration. And then the bowel obstruction that Samara just brought up. This is actually common to diabetic. It's a very shitty way to go.
That one was good.
Yeah, well, he's under 18, he can make those jokes. He's not going to jail. Any questions?
That's what you see. I think it's still.
Acute abdomen in geriatrics is often more fatal than it is with non-geriatrics. Things you should know. Any questions? I just have a brilliant idea. No questions?
What's your idea?
I cannot say that in the EMT class, but it's in my head and I'm gonna use it in the future. Has nothing to do with this class.
I know that, but whatever.
All right. Altered mental status. So dementia is common, so is Alzheimer's. Usually develops slowly over a period of years. They have good days, they have bad days. But it's different than delirium. Delirium can have a lot of different causes, most likely UTI. Any questions? Psychiatric emergencies are common. Depression is very common. Especially when associated with physical pain, loss of loved ones. So women are more likely to suffer depression, but men are more likely to take lethal means when discussing geriatric populations. Any questions? Oh, look at that. I just think I knew it was coming. Any questions? Any questions? 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 A question.
So I have a question for you.
All
I know
right.
it's outside class kind of, so it was on one of the ride-alongs. One of
Uh-huh.
the people I knew had like a history of suicidal thoughts.
Okay.
So say if you ask them that question because they called you in, you knew about their past, they called in multiple times, right?
Okay.
So you found out that they have been overdosing on their like Vicodin or whatever.
All right.
So would you ask them about the suicidal thought? And then they say, well, I wasn't trying to kill myself this time. Would that be a thing of like suicidal thought? Or no?
Well, it'd just be part of your assessment. You'd say, like, if you suspected they overdosed, I'd say you would ask, did you intend to harm yourself? That's just what you would ask.
Oh,
That's how you handle it. If they say yes, then you need to involve law enforcement, because if they refuse, you don't have the authority to take them under involuntary. But anyone that has intended to harm themselves falls under danger to themselves.
okay.
So they should meet the criteria. Any other questions? All right. Advanced directives, remember. Patient can give a full override at any time. Can't go. Man, I'm sorry, dude. Decided an advanced directive can't help you. It's what you ripped at. They can verbally override that anytime they want. Advanced directive is what their instructions are in case they can't communicate with you. Any questions?
We said that they can say, actually, no, I don't.
Yeah. They can verbally override an advanced directive anytime they want.
So, but how does that work?
On a DNR.
But even a DNR, they can override a DNR if they're still awake.
How does that work legally? Like, how can, because can't they just be like,
Because legally, the advanced directive of the DNR is that they can't communicate with you, like they are hard stopped and they can't tell you, I don't want CPR.
I think they have to be like competent and like.
Well, yeah.
Alert and oriented and stuff like that.
But yeah, but they can verbally override it anytime they want.
Even if they're altered,
Huh?
even if they're altered.
Not if they're altered.
So like if they're like telling you, help me, and then they go unresponsive, but they have a DNR,
The DNR is void.
okay.
we kind of get screwed over legally like that? Like,
I don't think so. Usually there's gonna be at least 3 or 4 of you that need to witness it, often law enforcement, sir. So if they're saying, please do everything you can to save you, and they go. Then you do everything you can to save them, despite the DNR. Now, hopefully. Whoever did the DNR, the advanced directive. Gave the proper counseling, and that wouldn't be an issue, but that's becoming rare and rare in today's society.
And this is all that doesn't matter if they're altered at all.
Yeah, if they're severely altered, then you just go with what the advanced directive says. They gotta be a competent adult. When in doubt, make base hospital contact and put it on them. Elder abuse, believe it or not, has all the same flags as child abuse for the same reasons. Just like child abuse, it's largely hidden from society. Just like child abuse, it's often not reported because it's our only caregivers. Very, way more prevalent than what people think. Any questions? All right. Oh. Skilled nursing facilities, people that have no visitors have the highest incident of neglect and abuse inside nursing homes. And that's a fact, Jack. I mean, undeniable that. Any questions? If nobody's checking on them, they're the last ones to get care. Sad. Any questions? Flags. Pretty much the same as kids. One of the big one is psychosomatic complaints. That's where a patient's got a complaint. And as soon as you get them out of their environment, the ambulance door closes and you're headed to the hospital, the complaint resolves. So that psychosomatic complaint was just to get them out of the environment they're in. That's a huge flag for elder abuse. Any questions? Any questions? More flags. Know your flags. Any questions on flags? And then, of course, there's the actual signs that you can see. Healing of various stages. Bruises, bites, and burns. The 3 B's. I just made that up. Any questions? Shouldn't call them 3Bs, we should call them killer bees. Killer bees, geriatric flags. We're on to something.
Right on board.
The Gems Diamond. Bring it with you to all geriatric assessments. Any questions on the Gem Diamond? So things to watch for, be keenly aware of the environment. Do they have food? Is the house the right environmental temperature? They have a ton of stairs, they have access, or they snowed in. Is the scene unsafe? For the patient, how we go. Any questions? What is the environment? Is it clean? Do they have heat, lighting, food? What's their personal hygiene? Are they able to get dressed? Any questions? It's not uncommon, the summers and the winters of Chicago, New York City, Buffalo, that you lose a couple hundred geriatrics due to environmental conditions. Air conditioner breaks down 90 degrees outside with 85% humidity, those people are toast. Literally. Any questions? Never assume altered mental status is baseline. If there's anyone else around that knows the patient, always check what baseline mental status is, and this is normal for the patient. And I promise you that will be a test question. Any questions? Your sample is going to be a huge, huge help to your Gems Diamond. Any questions? Medication history also gives you a good clue to their history. Any questions? Why is that pharmacist smiling? Because she knows she's getting rich off geriatric patients. Any questions? Again, geriatric patients cannot compensate like younger people do to changes in vasculature. Any questions? Most common complaints in geriatrics. Damn kids. No, just kidding. Let's stop. Damn younger generation. Dyspnea, which shortness of breath, chest pain, altered mental status is probably the most common. But all of them are common complaints in geriatric patients. Any questions?
Which ones did you say are the important ones to make note of? Obviously, you want to make note of all of them, but like which one?
Well, dyspnea, chest pain, altered mental status, absolutely, and any trauma or falls.
Yeah.
Also, when someone falls, anyone falls, but especially geriatrics, find out what the mechanism is. Did they have a syncopal episode and fall? Did they faint? Or did they trip over something? Because it can make a huge difference. If it's syncope, it could be from an underlying medical condition that caused the fall that you don't want to miss on your assessment. So if someone's had a fall, the first you want to ask is what caused the fall. Any questions? Most common traumatic injury to geriatrics is ground level fall. I think we get at least a dispatch a day in this county, if not 4 or 5. Followed by cockwash. Followed by hit by fall. And then of course birds, because they sometimes will burn themselves because they don't have the sensory perception of their nerves like you and I do. So sometimes they get into water that's too hot, heated blankets, hot tubs. Any questions?
Also, then your skin's thinner, right?
It's thinner and the sensory nerves do not work as well. What are the compounding factors of trauma in geriatrics? Well, pre-existing medical conditions that don't allow them to compensate and or heal. Dentures or other dental implants that take a shot in the face become arrow obstructions. Decreased ability to compensate. Another change is associated with aging. That's kind of an umbrella term. It tells you nothing. Because there's a lot of them. Any questions? Good news is, unless they have deficits and if they're fully alert, we don't have to put them on boards because that was pretty brutal putting geriatrics on boards, especially geriatrics with kyphosis. So kyphosis is a curvature of the spine. Then you just have to put padding underneath it to make it all. Otherwise, it's like a weeble wobble. Not good. Unfortunately, you don't generally have to do that anymore. Any questions? Head traumas don't go well. So 1 in 3 geriatric people that strike their head end up with an internal brain bleed. That's extremely high. And if they're on blood thinners, it's even higher. A lot of these people are on blood thinners. Right, Wyatt? Just so excited to be here. It's almost as excited as that. One in 3. So when they try to refuse treatment, you got to make sure you advise them of that. They should really go in and get a CAT scan. Any questions? Hip fractures are also common in geriatrics. They fall ground level fall, snaps the head of the femur off inside the pelvis. Proximal femur is just floating around free. Not good. Good news is when I started in this back in the dark ages, if you were over 80 years old and you broke your hip, you'd be dead in a month. It just was not survivable. Nowadays, people are home the next day. Let them get surgery, go home. This medicine's come that far. Any questions? What do you do for hip fracture? Pillow between the legs. Try to make it comfortable, strap it in. Do not use a pelvic binder. Any questions? We're just blowing through this. It's getting tired. Determining chief complaint is challenging because there can be language barriers, age barriers, dialect barriers, sight, hearing, and speech barriers. Don't see the fear of hospitalization like we did 30, 40 years ago, where people only went to hospitals to die. Most of our current geriatric community understands hospitals aren't the place you go to die anymore. Now it's just the opposite. You stay at home to die. Any questions? So other signs, symptoms of silent heart attacks, besides just shortness of breath, weakness, nausea, sweating. Toothache, singular arm pain, singular back pain. I know one guy that was a big time golfer who for like 2.5 years couldn't walk an entire 18 holes. His hips started hurting the more he walked. So he took a golf cart and one day, I think he was difficulty breathing and weakness. And we took him in and he was having a heart attack and they went through and they capped and they did PCI and opened his arteries up. And a week later, he got to go golfing and he was able to walk 18 holes. So the hip pain was actually angina. Just an atypical presentation of angina. Any questions? Dyspnea. Lots of causes of dyspnea. But most likely it's going to be a COPD in a geriatric patient or congestive heart failure. They also are very susceptible to pneumonia. Don't withhold oxygen. Any questions? Yes.
What was the thing we had to look out for COPDs for if we over oxygenate?
Oh yeah, after like 24 hours, you'll wipe out the hypoxic drive.
Yeah,
Then they'll stop breathing. Then what would you do? Bag them.
yeah,
EVL, that's what you're trained to do.
okay.
It's just really hard to wean them back up to ventilator. Any questions? But it takes a long time, like you'd have to be hours. It's not gonna be your problem as an EMT.
Okay.
Any questions about syncope? Going somewhere? All right. What is the mnemonic for altered mental status in everyone? Very good. Any questions? Any questions about acute abdomens? Generally happens when perfusion inside the abdomen is less than 90 degrees. It'll cause an acute abdomen. Okay, I'll word it down. I'll show that. I don't know. Sepsis is another huge problem for geriatrics. Being old is no fun. It is highly dangerous. So what are the signs and symptoms of septicemia? The same as it is for young people. Any questions? Well, SNFs. Skilled nursing facilities. The skilled nursing facilities, get a really tough rap from EMS, constantly. But it has, 'cause there's, the hell. There's a lot of different perceptions. So in a SNF, the staff at the SNF, they're dealing with this every day. They've got routines, they got things like that, and they are also not generally trained the same as an EMT to look for the things you're looking for. So things that are blatantly obvious to you as an EMT may not be to the SNF staff. Generally, also, most SNFs are in a situation of overworked, lots of patients for minimal staff. So it's not uncommon to be let into a SNF and be shown where your patient is and never see the staff again. It's not uncommon. Any questions? And the patient's not able to answer your questions, you just gotta go with it. It's important if you go to a SNF to try, if at all possible, get a history and physical from the staff. They can bring it out for you. Hopefully. It's called an H&P. They pronounce the entire patient's chart record of their history of physical, why they're there, what their problems are, allergies, medications, etc. So if you're able to get that from the staff, you absolutely should. Any questions? That is the end of geriatric emergencies. Huh? We're way ahead again. And that is not the syllabus. Got rid of my syllabus.
That was 36.
So tonight is March 16th, so we're gonna do obstetrics and neonatal care tonight.
Yeah, I thought we
Are
did.
you arguing? All right, why don't you guys take a 10-minute break? Come back at 7. I need team 1 here,
Yay.
team 2 here, team 3 here, team 4 there. And we're gonna play Wheel of Fortune.
Game changer.
Family Feud. I'm gonna work on that, an EMS Family Feud. That's a good idea. Survey says foreign body obstruction.